Good morning, everyone. Thanks for the opportunity of speaking to you this morning. I hope we have a pleasant conversation about traumatic brain injury. I'm Joe Graciovi, one of the neurotrauma attendings in the department. Today, we're going to talk about TBI, briefly about the social impact. We'll discuss some clinical cases. We'll talk about the compressive craniectomy because the guidelines have recently changed. We're going to talk about the ICP and PBTO2 based management, a little bit about outcome prediction and augmentation in TBI, about future perspectives. So naturally, when we talk about TBI, people tend to think about a young adult or a kid having a car crash, or maybe the military coming back home after the most common cause of trauma, which is a blast injury. But in fact, this is a silent epidemic in our society, and the scenario is changing. Around a third of the patients that suffer TBI these days are over 65 years old. And the most common cause of TBI is actually fall. Those patients are frequently using anticoagulants and antiplatelets, and half of them have important comorbidities. Around a quarter of the patients are involved with use of alcohol and prescription or recreational drugs when they are committed by TBI. So this is actually so important that it became a matter of public health activities trying to reduce the abuse of alcohol and drugs to prevent fall and violence-related TBI, as they are frequently encountered in the studies, including this one that was done in 18 centers in Europe and one center here in the US, where this data come from. TBI is the second most common neurological emergency, and it's a heavy financial burden as well for the states, with costs going over $100 billion per year and worldwide over 400 billions. 10% of the TBI patients present with a severe TBI, but of course, those are the ones that take the most part of the budget. So let's discuss about a case now. I'd ask if our the resident that is rotating in trauma with us, Vignesh, are you on the call? Could you please answer? Ignacio, can people answer to me?
Yeah, everybody can
Hey, Joe,
communicate.
we can hear you. Yep.
All right. So, Mike Silva, would you be on the call? Would you like to help us? Anybody? All right then. Let's imagine this case that we have a female patient that is brought after a fall, 2 days after a fall, with the GCS of 7T, intubated with only localized stimuli. The patient is anisocoric, with the right pupil larger than the left one, with the left hemiparesis. The CT shows an acute subdural hematoma with a large midline shift. What's the way to go here? It's clearly a surgical case, but should we just evacuate the clot or should we decompress the patient in the first surgical moment? To help with this decision, there is the hematoma midline shift ratio. Naturally, that case that we were discussing about is surgical because the midline shift is over 5 millimeters and the thickness is over a centimeter. And the ratio helps us to decide if we need to decompress or not in the beginning. So the lower the ratio, the worse the prognosis. And if this difference is over 3 millimeters, it's even a predictor of higher mortality. And this makes sense because if you have more shift than hematoma, this means there are underlying lesions in the brain parenchyma that we cannot see. Edema, hidden contusions. So we are likely to decompress in the beginning. That's the answer for the question, but this is not clear in the literature. This Japanese study with over 1,000 patients where half underwent craniotomy and half decompression, mortality did not differ, length of stay was actually longer in the decompression group, but they analyzed in the subgroup analysis that patients with severe TBI and high energy injuries are better candidates for decompression. In this study with over 2,000 patients, the efficacy was the same from craniotomy and decompression, and craniectomy was associated with a lower rate of residual subdural hematoma. And lastly, in this study with around 2,000 patients as well, craniectomy was related to a higher mortality, but this was not matched according to the severity of trauma. And this is natural to have a higher mortality in craniectomized patients because we likely undergo this route in patients that present more severe cases. All right, in the patient we were discussing about, a right-sided decompressive hemicraniectomy was done. And for the juniors, it's important to remember that when we do the craniectomy, we should go as low as possible in the skull base towards the floor of the middle fossa to remove the cone of pressure that can build up with increasing intracranial pressure towards the brainstem. All right, let's move on. So we were just talking about a case in which we decompress the patient primarily. But now let's move to a different topic, which are patients with diffuse traumatic brain injury that eventually become with elevated ICP, which is refractory to the medical management. So this topic is about late decompression or late decompressive craniectomy. Okay. The current guidelines from the Brain Trauma Foundation, they were written in 2016, the 4th edition. They state with a level 2A evidence that bifrontal decompressions are not recommended to improve outcome in patients with diffuse injury without mass effect. And also, if you do a craniectomy, it would be a unilateral, but not less than 12 to 15. It makes sense because you don't want a small craniectomy where the brain herniates, compressing cortical veins, and promoting venous infarcts in the brain. It's interesting to mention that when the guidelines were published, the results of the rescue ICP trial were still pending, and they even stated that those guidelines might change when the results would be published. The first recommendation not to decompress patients with diffuse craniectomy were based on the DCRA study, decompressive craniectomy in diffuse traumatic brain injury. In this study, 155 patients with closed TBI were studied. The criteria for decompression, for randomization into decompression or conservative treatment was if the ICP was over 20 millimeters of mercury for more than 15 minutes within 1 hour in the first 3 days of trauma. So this is an early decompression. DCRA is an early decompression, okay? Well, the result that we were obtaining, those patients were taken to a bifrontal temporal decompression with a mouthfish open at the dura mater. And unfortunately, this study failed to show an improvement in functional outcome. So the Glasgow outcome scale, the extended version, was used to quantify prognosis. And let's remember how it works. We have 8 degrees. The first 3 are considered a bad functional outcome, which are death, degenerative state, and low severe disability. The upper severe disability is already an interesting outcome because the patients in this case are capable to care for themselves at home. So GOSE 4 and more is interesting. We want a good functional outcome. We want to achieve those numbers, and the higher the better. So in the DCRA study, unfortunately, neither in 6 nor 12 months, they achieved an improvement in the functionality. Okay, we talked about early decompression, but now we're going to talk about the rescue ICP trial, in which a late decompression was performed for diffuse injury. In this study, around 400 patients were gathered to be analyzed. They had basically diffuse injuries, and they underwent, after randomization, either a bifrontal temporal decompression or a unilateral decompression according to the imaging. If it was a diffuse swelling, diffuse edema without any side predominance, bilateral. If one side was predominant, naturally a unilateral decompression. Okay, the criteria were more relaxed comparing. So the ICP threshold was set at 25 millimeters of mercury, and the patients should be refractory for over an hour instead of 15 minutes. And they were recruited from 1 to 12 hours of increased ICP and up to the 10th day. Let's think about it. If you have a patient that becomes with a refractory elevated ICP within the first 3 days, this is not even in the peak period of the brain edema. So we naturally interpret this as patients that are very severe, with likely a primary lesion that was either non-survivable or very critical. It's natural to expect a worse prognosis in the early decompression. This study was focusing, as we understand, on the patients that would be more viable. We cannot predict very good yet with biomarkers or other issues, which of those patients will be viable to aggressive treatment. But this rescue ICP study, this gives us some insight in this matter. All right, so going back to the results, those patients, they were decompressed later on with a higher threshold or ICP, bilateral or unilateral. And the other group that was compared underwent the current conservative treatment with barbiturics and hypothermia as well. Let's take a look at the results. Not only on 6 months, but also on 12 months, the late decompression was able to provide not only a lower mortality, if you compare on both time periods, but also a better functional outcome. And this is very interesting. Remembering that GOSC 4 or more is an interesting outcome. If you compare, it was better in the surgical group. If we look each level of the GOSC scale, we can see that in the surgical group, the upper severe was superior, the lower moderate was a little superior, upper moderate equivalent, the lower good was very superior, and the upper good was equivalent. And all this reached statistical significance. This was a very interesting study, and it was a game changer. Even so that a recent publication came up changing the recommendation from the Brain Trauma Foundation and backed up by the AANS and the Congress of Neurological Surgeons. And the current evidence, level 2A, and the current recommendation is that patients with late refractory ICP elevation are recommended to undergo late decompression to improve mortality and overall outcomes. But an early decompression, according to the DICRA study, is not recommended for improvement of mortality or functional outcome. Regarding ICP control, it can be performed in the beginning, according to current guideline, but the association with ICP control and prognosis remains uncertain in those cases of early decompression. Then the bifrontal temporal decompression that was almost forgotten for trauma, it's back in the game. So I thank Dr. Komotar because he published this video in the YouTube when he was still in New York, and it's a totally success. When I downloaded it, it was presented over 111,000 views. So let me take advantage of this video. Thank you, Dr. Komotar, in which you showed the procedure, the Kuber procedure, in which a classic bicoronal incision is used to expose the frontal temporal area. The dissection is done in a way to preserve the pericranium. This can be done with scissors, with scalpel, or dissectors. We can use field clamps or fish hooks to expose the frontal area. It's important to do a careful dissection when we go closer, of course, to the facial nerves on over the frontotemporal area. And it's also important to remember that the bone flap exposure has to go very anterior, exposing the orbital ridge. So the orbital rim, sorry. So after we do the exposure, with the 10 blade, the pericranium is divided posterior closest to the coronal suture over the temporal lines, and it's gently elevated with the periosteal elevator, for example. This can be used later for reconstruction, for example, if desired. So you see the bregma, the coronal suture here, you see this elevated. So the goal of the craniectomy is to remove the temporal bone, this part of the temporal bone, and to expose very basal, the anterior fossa. You see here drilling over the superior sagittal sinus, the root of zygoma, borehole is being done here. We can also see the keyhole being performed on the right side. The foot plate is being used to convert into a big bone flap. Of course, it's extra care in the dissection over the superior sagittal sinus is important. And after our frontotemporal flap is removed, we protect the superior sagittal sinus, and the craniotomy can be enlarged towards the parietal, the sphenoidal wing, or the skull base, and not only the middle fossa, but the anterior fossa, to have it flush with the orbital roof. This is important because if you think the vector of swelling goes anterior, and to allow the brain to expand anteriorly, we need to dissect it and of course open on an stellate fashion with remote as the opening is carried out into the midline, it's important to ligate the superior sagittal sinus. Typically, what is used is a double 2-0 silk, two sutures in which the sinus is divided between them, and the falx is also divided. This, again, to allow the swelling towards the anterior portion of the encephalon. Here you see the ligation of the superior frontal sinus in falx division. So DuraGen can be used to protect along with the dura and the pericranial flap. Okay, so let's discuss another case. Let's see if we have some residents that would like to help me. Eva, are you on the call?
Yeah, I'm here.
Thanks. So in this case, we have a male patient with multisystem trauma. The patient was arrested when he came to the ER, to the trauma bay, and then he was rapidly resuscitated. The patient presented a GCS of 2, was opening the eyes to pain, was intubated, and was withdrawing the extremities symmetrically, the 4 extremities, and had isochoric pupils. And then the CT was done. And could you please tell me what you see there?
So it looks like the basal cisterns are. One second. It looks like the basal cisterns are effaced. Like the brain is diffusely swollen. There's no like focal lesion that's causing the swelling. It's just diffusely swollen.
Very good. And here, what do you see regarding the midline?
Oh, then there's no midline shift. Very minimal.
There is a small midline shift. Yes. Very good. So this would be classified as a diffuse injury with using the Marshall classification grade 3, where the midline shift is less than 5, and the basal cisterns are compressed or not visible. So what would you do in this case, Eva? Do you think it's for conservative or surgical treatment in the beginning?
Because there's no focal lesion that's causing all this edema and everything, there's nothing like you couldn't really take out the whole, like you couldn't take off the skull everywhere. And so you would just have to do just ICP monitoring and manage conservatively and no surgical intervention for this person.
Very good, I agree. This is for initial conservative management guided by ICP. As you mentioned, we would use like either an intraparenchyma or an EVD to monitor. Very good. And let's imagine that after you place the EVD or the ICP, the bolt, the ICP is high. What would you do to treat it?
You could start with, raising the head of the bed like 30 to 45 degrees. Make sure that if the patient has a C-collar, their neck isn't kinked and that, it's straight. Then you can have the ICU team temporarily hyperventilate them to 35 to 40, and then keep sodiums greater than like 150 to 155, like osmos less than 320, and do 3% and go from there.
Very good. So thank you. Appreciate it. So you were talking about the measurements like hyperventilation, osmotic solutions, hyperosmotic solutions, mechanic measures. And if we look at the current BTF guidelines, they give us the evidence about it. But we can also use another tool to guide us to treat it conservatively, at least in the beginning. So recently was published a consensus from an international conference that was held in Seattle, where 42 experts in neurosurgery and neurocritical care gave their opinions, and they came up with a tier-based approach to help us manage those patients. Those rules are not written in stone. Of course, you don't need to exhaust every tier to move to a second one. It's not like a very hard recommendation, but it's more to help us to think progressively as the patients need to stratify the treatment. So every severe TBI patient needs an ICU environment in which the patients have a secure airway, the end-tidal CO2 is monitored, the CPP is held between 60 and 70. As you mentioned, we need the monitoring. Also, A-line, central line, we prevent anemia. Of course, we do the neuro and give an hour. As you mentioned, the C-collar helps to maintain the head midline and IJ compression, head of bed elevator, proper analgesia, sedation, and we typically use anticonvulsants for the first week to prevent early seizure. All right, and so we have our monitor in place, and we see that the ICP is over 20. For example, that's the reference that we could use in this case. What do? We typically, according to the tier 1 recommendation, we can do mild hyperventilation. We can use the osmotics, as you mentioned, taking care to keep the osmolality below 320. We can drain CSF, and it's important to rule out non-convulsive seizures, of course. Again, I'll just state B, C, and D, like the ATLS guidelines, but it's not a sequence. Of course, they are done almost simultaneously. All right. And if the patient has still elevated ICP, it's important to repeat the CT, of course, to rule out, as you mentioned, mass effect lesions. And in this case, we were discussing the CT was repeated, and we see the evolution of brain edema, some scattered subarachnoidal, some contusion. The cisterns are still compressed, but we didn't see any big hematoma or a big midline shift, leading to the decision to move to an evacuation. All right, then we evolved to the tier 2 approach. In the tier 2, we can do a more aggressive hyperventilation, but still over 32 at least, because we don't want to cause vasoconstriction, excessive vasoconstriction, and brain hypoxia. And this is interesting to mention, the MAP challenge. The concept of MAP challenge is the stepwise increase in MAP in steps of 10 millimeters of mercury, looking for an optimal MAP value to improve the ICP and CPP. In patients with intact autoregulation, what happens is that as you increase the MAP, you see a decrease in ICP up to an optimal value. And the CPP, as a consequence, is optimized. Okay. Of course, this is present in intact autoregulation. And also, we can use paralytics at this stage. So if we are already hyperventilating, we optimize our MAP, we're using osmotics, we paralyze the patients, and it's still refractory, the ICP, we need to move to the tier 3, a more aggressive approach, the last tier, in which we can either go for a decompression or intensify the conservative measures with barbiturics and mild hypothermia. It's important that we don't, not to use excessively barbiturics, not to induce hypotension, myocardial depression. We're just targeting burst suppression, okay? Or we can go to a decompression. In this case, the patient was decompressed, the midline is centered, and we see the improvement of the ICP with unfortunately contusions that blossomed. Okay, so we saw the ICP-based management, but is normal ICP a guarantee that the normal brain is being oxygenated? Can we always hyperventilate to treat elevated ICP? To answer those questions, we can use the brain tissue oxygen monitoring. It's available at the GMH, and this is part of the concept of the BOOST study. The BOOST phase 2 study was held in the past in 10 centers, including our university. In this study that is focused on brain oxygen optimization, it gathered 119 patients with severe TBI, and all of them were implanted with ICP and PBTO2 monitors. They were randomized into 2 groups. The first group, both values were visible and they were taken into account to decide about the clinical management. And in the second group, the PBTO2 recording was blinded. It's interesting to see that as a result, the group in which both parameters were taken into account for management, it was very significant, the reduction in brain hypoxia time in the group where the brain tissue oxygenation was monitored. The ICP control was equivalent, and very likely because of the number of participants, the statistical significance was not reached, but there was a clear trend in reduction of mortality and increased good outcomes. Therefore, the BOOST 3 trial is currently underway in 45 centers in the US, and we are very anxious waiting for the results. All right, but how do we use the PBTO2 catheter? Let's imagine the scenarios. And let's keep in mind that we never hyperventilate an hypoxic brain. Instead, we increase O2. Why? Because when you hyperventilate, it promotes a vasoconstriction in a brain that is already hypoxic. That's not desired. Okay, but increasing oxygen is a good way to go. Let's imagine the first scenario, a patient with elevated ICP but normal brain oxygenation. We treat as we discussed before in the tier-based management. We can use mild or moderate hyperventilation to improve ICP. But in a patient with hypoxia, we cannot hyperventilate. Let's imagine this scenario in which the ICP is normal, but the brain has hypoxia. We increase the O2 offer, mild or more aggressively, and we can even hypoventilate a little the patient to promote vasodilation, as long as the ICP is normal, to improve brain oxygenation. And in the last and worst scenario, where the patient has ICP elevated and the brain is hypoxic, we can use hyperoxia, but we don't hyperventilate, and we can migrate to other measurements, including decompression. It's important to keep in mind. Remember, hypoxic brain, we don't hyperventilate. All right, so we discussed up to this point of the presentation about the management of TBI, conservative, surgical, but how to deal with the aftermath. After the acute phase passed, and the family comes to us and asks the patient, doctor, is my father going to improve? Is my son ever going to be back to normal? Those questions regarding prognosis are very hard to answer. Therefore, we have some methods that can help us. For example, the impact prediction model. This is interesting. There is a website in which there is a calculator that takes into account clinical, imaging, and lab parameters at the admission and help to calculate the mortality and functional outcome in 6 months. I'm bringing this study, it's not new, but the study is in which the data were validated in over 8,000 patients with moderate and severe TBI. So this can be helpful when discussing about prognosis and how to go. And the prediction can be even improved if we couple this to DTI analysis. For example, this paper shows a post-processing with 20 regions of interest that, coupled to the impact score that we just saw, can increase the sensitivity of an unfavorable outcome to 64% and specificity to a 95%. So remember, impact and DTIs as a good way to go for prognostication. At least you have some idea and discuss. Okay, let's talk a little bit now about future perspectives. Where is the treatment? Where is the research of brain trauma going? In our institution, I'm glad to describe that we have 15 ongoing clinical trials involving TBI patients. We have a monthly meeting with the team of Dr. O'Phelan, the neurocritical care, Dr. Gillian Hotz, that is on the call. I saw her and her group. We discuss the progress that we're doing on different studies on a monthly basis. And we are, of course, helping ourselves to foster all of them. I'm not going over all the studies, naturally. I'm just gonna mention some of them. As the Track TBI, which is a consortium here in the US with 18 centers with level 1 trauma management, it's a prospective observational study with several sub-studies comprised. As the SD2 study, for example, in which we studied spreading depolarizations. We know that SDs are part of the mechanism that leads the brain to secondary injury and traumatic brain situation, also present in vasospasm on subarachnoidal hemorrhage. We can also see this in migraine. So SD is extensively researched these days in different pathologies. We are part of this sub-study here in the university, and patients, according to their managements, are assigned to 3 groups. If they don't need invasive monitoring, scalp EEGs are used to analyze the occurrence and distribution of the spread depolarizations in the core and around the lesion. If the patients undergo open surgery, subdural strips are implanted, and if not, intracortical electrodes are used. It's important to mention that spread depolarizations, as they are linked to worse prognosis, because what happens is when this massive wave of depolarization starts and spreads in the cortex, it leads ultimately to cell exhaustion and death. And it can be as a countermeasure, it can be used like ketamine, for example, to antagonize the NMDA receptors and maybe improve prognosis. There are publications about it, so we're looking into this. It's another very interesting study that just started in our institution. Thanks, Danny Samana, for the slide. Is the Iscat Tbi Test, in which blood samples are taken from patients with mild TBI, and biomarkers are searched in the blood samples, looking for brain neuronal lesions and glial cell lesions as well. Another study that is interesting is the EpiBios, in which epileptogenesis related to traumatic brain injury is analyzed using clinical imaging and electrophysiologic data to help understand and mitigate the generation of seizures in patients with TBI. All right. In this last part of the talk, I'd like to talk a little bit about augmentation in TBI. So let's start with neuroprotection. I'm very glad that recently we partnered with Dr. Dan Liebel's lab. He has very striking findings for neuroprotection in traumatic brain injury. For example, the dependence receptors. He recently described this new class of pro-apoptotic receptors in which a ligand like FRNB3, in response to cellular stress like TBI, loses the connection with the dependence receptors. And then what happens? As a result, there is a cleavage of the intracellular receptor and an exposure of the intracellular domain in neurons. So this exposure leads to activation of the caspases, and this process culminates with apoptosis. This happens after the cellular, the TBI, and this continues in the first days or weeks after injury. It is interesting, it's very interesting to say that in animal models, he could inhibit this process, blocking cell death and improving functional recovery. So this is a very interesting approach when we want to improve neuroprotection. Therefore, we are translating these findings into human TBI from intraoperative samples of contused areas in the brain. And we're anxious to see the results. Another strategy about neuroprotection is not only to prevent cell death, mitigating the effects on death or dependence receptors, as they are called, but also to block synaptic damage. Let me talk about D-serine. The D-serine is a co-agonist of glutamate when activating the NMDA receptors. It's normally produced and released by neurons. In the setting of trauma, what happens? The glial cells start to produce right after the trauma, and it's extended for days after the trauma. They start to produce the D-serine, the glial cells, and this production is very high, and this leads to a hyperactivation and leads to synaptic damage. So also in animal data, Dr. Liebel could see that blocking the production and release of D-serine, this led to a block in the synaptic damage and ultimately improved functional outcomes. So we're looking into that in intraoperative samples as well, translating these findings into human TBI. All right, moving from neuroprotection to neuromodulation. Let's talk a little bit about vegetative state and MCS. We know that around 14% of the patients that suffer severe TBI are discharged in vegetative state. And this is sad because the vegetative state is that state in which we see no signs of awareness. The patients don't present eye tracking, they don't respond to voice. It's important to say that this is different from minimally conscious state in which we see definite but minimal signs of awareness. What can we offer to patients that are discharged and evolve to this state? Dr. Jagged, Ian Cahigas, and Damien just did a very beautiful review on the literature about deep brain stimulation for disorder of consciousness. So they showed in this study that the major of authors, sorry, they implanted leads in the central thalamic region to treat vegetative state and minimal conscious state. As a result, around half of the patients presented at least some functional improvement. So there is definitely room for more research on this area, coupling to new imaging, functional imaging, and to new technology, maybe looking for different paradigms or new targets for deep brain stimulation for disorders of consciousness. But also, neuromodulation could be used with the vagus nerve stimulation, the VNS. animal data present interesting evidence of a beneficial use of vagus nerve stimulation in the acute phase of TBI. It was shown to reduce serious hyperexcitability. The VNS stimulation in acute setting has anti-inflammatory effects. It reduces the blood-brain barrier breakdown, improving cerebral edema and improving synaptic plasticity and the endogenous recruitment of neurostem cells. Well, the animal data look promising, and now maybe with this publication of last year, in which this Danish group demonstrated the safety and feasibility of German prosthesis coupled to patients in the setting of an acute TBI. This is a transcutaneous way to stimulate the vagus nerve, not invasive at all. So maybe we could use this tool to start researching more on this topic and see the efficacy of this approach. And lastly, briefly about neurostem cells, which would be the third way to go in augmentation for trauma. Typically in the stem cell world, we have neurostem cells and we have mesenchymal stem cells. So this recent review gave details about 9 clinical trials that were performed in patients with severe TBI, and the results seem promising with the use of mesenchymal stem cells, especially bone marrow and umbilical cord stem cells, in which damaged brain areas could be regenerated, and we saw some improvement. So this is a promising way to go as well in the augmentation for brain traumatic injury. So in summary, during the talk, we spoke about the changing scenario of traumatic brain injuries in which the elderly population is presenting more and more trauma, mostly because of falls, and keeping in mind that anticoagulants and antiplatelets and alcohol use play an important role in the BTI. We saw about the ICP tier-based management according to the Seattle International Consensus, and also the role of brain tissue monitoring in the management of the patients with severe TBI, in which we need an ICU treatment. We saw, based on the rescue ICP, that the guidelines for craniectomy changed. The late decompression for diffuse injury is now recommended to improve outcome. The early decompression remains very controversial. We can use some tools to predict outcome like the impact score, and thinking about augmentation, neuroprotection, neuromodulation, and neuroregeneration are promising strategies to improve the treatment of TBI. And last but not least, once it happens, it's very hard to treat TBI. So naturally, prevention is the most important thing in TBI. So because once the brain is damaged, it's hard to manage and almost impossible to regenerate. Thank you very much for the time and attention.
Great talk, Joe. Very nice. Enjoyed it very much.
Thank you, Dr.
Hi, Joe. This is Christy. That's a wonderful talk. Can I just put a plug in for our new unit and the ability to do some of the monitoring that you mentioned in our new space, that we will have ICM Plus software available to monitor these patients, to be able to collect physiologic data and to look at things like CPP optimum and PRX, like you spoke of, for autoregulation in these patients. And we have monitors that can look at autoregulation over a longer period of time, 12 hours or a couple of days, to be able to track the response to our treatments and our hemodynamic things. We will have the Lycox monitors available with bolts in the new unit. The nurses have been trained, so we're ready to go with that. So I think it's a really exciting time, and we're so happy to have the inertia and the momentum in the neurotrauma group that you spoke of and that you're supporting. So thank you very much.
Thank you very much for the comment, Dr. O'Fallon. Congratulations, your new home is really beautiful. Looking forward to contribute more and more to the management. It's important to mention that we need to train our residents to the implant of the PBTO2 monitors, and I'm planning to coordinate like the hands-on training on it as well.
Can I just add, it's Jillian, that Dr. Joe, that was a great overview. And we have to remember that, 80% of brain injury is mild. So the numbers are still on the one side. And we've now done a really good job with all our support now from our neurotrauma unit and the residents and fellows and most of you, that we've got a really good setup now to follow these folks in sports and non-sports. We hired a sports neurologist that's taking on some of the non-sports in clinic on Thursday mornings at Lennar, and we'll probably be adding another clinic, and we're working on a QA with trauma to take a look at some of these numbers, our real numbers of mild brain injury that are coming into Ryder. Again, there's a real good focus on that with Dr. Ye and Namias because the numbers are so big, and we're trying to figure out how we can bring back the IHI, which can really assist us managing some of these milder patients. So with the help of Dr. Jagged and Dr. Joe and Dr. Iam and Dr. O'Fallon, we've really been trying to improve the management of all comers with brain injury. So thanks a lot for the talk and bringing some of the awareness back to our program and the department.
Thank you for the joint work, Joe. We appreciate it very much. Thank you.
Yeah, this is Dalton Dietrich again. Congratulations on a great talk, Joe. Just let everyone know that the Miami Project is really committed to helping the Department of Neurological Surgery, Department of Neurology, and other programs advance traumatic brain injury research at University of Miami. We have a very robust preclinical program in traumatic brain injury where we're looking at stem cell transplantation, vagal stimulation, those types of things. We're actually trying to recruit a new biomedical engineer from Ohio State who will bring new technologies in terms of neuromodulation targeting brain injury. And he has very good connections with industry. So I think that's going to enhance what Jonathan and Christy and Joe and Jillian and everyone's been trying to do for many years. So anyway, just to let you know, the project is behind this 100%. And I know Joe's in the laboratory working on some things with Dr. Liebel already with blood biomarkers. So I think there's a lot of translation. And we just got a new grant in terms of a mild TBI, repetitive insults. So, we're looking at all the pathophysiologies and hopefully we'll be able to build alliances more and more as we move this program forward. So projects behind Joe 100% and really excited about this new area of traumatic brain injury in the Department of Neurological Surgery, as well as the Miami Project and neurosciences in general.
This is awesome, Dr. Dietrich, and I'm very excited to work more and more with you as well and your team in the Miami Project and help to foster the clinical and basic research on TBI. Thanks again. All right.
Okay, if there's no more questions, we'll just move to our next speaker. Changing directions a little bit, we're going from traumatic brain injury to traumatic spinal cord injury. And as you know, the project for many years has been looking at various ways in which we can enhance recovery in subacute and chronic spinal cord injured subjects with stem cells, as well as autologous Schwann cells. And today, Dr. James Guest, who's professor in the Department of Neurological Surgery and a very important member of the Miami Project, is going to be talking to us about work that he and his colleagues have been doing in terms of neurophysiological insights into looking at circuit plasticity and connectivity after spinal cord injury. So Jim, thanks for being here today.
Thanks, everybody. I just want to check that you can hear me okay.
Yes.
All right, thank you. All right. Again, can everybody see the slide well?
Yeah, but we can see the other. Can you? It's not in presenters mode. Can you swap on the top left? Swap display.
Okay. That's better.
And now you're ready to go, doctor.
Okay, thank you for that. Okay, yeah, so today I'm going to talk about a neurophysiological study that we did in combination with a human clinical trial of cell transplantation and spinal cord injury. We published the index paper for this study in 2017 in the Journal of Neurotrauma. And I wanted to talk about the concepts that I'd like to go over today. So the first is, what might we expect the effects of Schwann cell transplantation to be in complete thoracic spinal cord injury? Because the particular study this morning enrolled people who were paraplegic Asia A, motor and sensory complete. I'm going to talk a little bit about the limitations of evoked motor and sensory potentials as compared to electromyography. I'm going to tell you that the thoracic level that we all sort of think about, which is based on the sensory exam, is an illusion with respect to what is really going on neurologically. And I'm going to talk a little bit about the implications of what we've learned from epidural and transcutaneous neuromodulation in people with motor sensory complete SCI. So this morning we're focusing on people who have a complete thoracic injury. And so briefly, this is what our trial looked like. We enrolled 6 subjects. They underwent a nerve harvest, and their own cells were grown in culture. And then at an average of 42 days post-SCI, all the baseline studies that included neurophysiology were done, and they went forward into the transplant if they were still neurologically complete, which meant that baseline they didn't have any evoked potentials. And then we brought them back and did assessments at 2, 6, and 12 months. So going back a little bit, what was this trial about? So you can see here on the bottom right that this was a truly, you don't call it invasive, spinal cord injury biologic trial. These cells were delivered right into the injury epicenter. And I want to talk a little bit about what we expected that these cells might do. So I'm going to show you a couple of slides of primate data where we made demyelinating injuries. And so here you can see a lot of demyelinated axons in a transmission electron micrograph. You see some acute inflammation by macrophages, which are going to take up the debris. This is myelin debris over here. And then at a year after injury, you see 2 different patterns. One is that there's some persisting demyelination, and the other is that there's been endogenous remyelination, and you see these small myelin rings here. Now, what does a transplant look like? So Schwann cell transplants in the central nervous system are really interesting because they, like in peripheral nerves, they form fascicles that have endoneurial fibroblasts around them, but they also include the processes of astrocytes. So these are astrocyte processes. So there's no place in the body where this actually happens, with maybe one exception. And so what you get when you put in a Schwann cell transplant is a unique tissue that doesn't, has components in it that we don't normally see. And this is quite a favorable picture. And so now we're moving to some preclinical work we did in pig models. And so we made the transplant labeled here with green fluorescent protein that you can see. And then this is the spinal cord injury defined by GFAP. And then we used confocal microscopy to ask if these green transplanted cells were doing anything. And indeed, they were right next to axons that had myelin on them, P0 myelin. So it seems very likely that the transplanted cells were actually able to form myelin. Now that's important because they've been outside of the body for weeks in cell culture, and then we're reintroducing them into a place they don't normally exist. And at least in this model, they seem to be able to form myelin. So that's one of the main things that we target in spinal cord injury with Schwann cells is myelin. I want to just bring up a few concepts here. So we're going to talk about people with complete injury today, and we're going to talk about the threshold of preserved function to actually see voluntary function or activity. So as you can see, this amount of preservation doesn't reach the threshold. So the idea with our grafts and our other interventions is to take this tissue and make it work better so that we can get to the point where we cross this bar of being able to perform voluntary functions. Now, people have been looking over the last couple of decades at the relationship between spared tissue and function. So this is from a group in Switzerland, and they looked at tissue bridges, which is basically how much tissue is spared in the dorsal and ventral part of the spinal cord. They quantified that, and they looked over time, over the first year from injury. And then they came up with some relationships, saying that these tissue bridges, the size of these tissue bridges at the injury epicenter correlated with the motor score, the sensory score, and other things. And I think that these sort of linear regression analyses are a little too simple. I think probably when we look at the relationship between spared tissue and voluntary function, it's not going to be linear. It's going to be exponential. There's going to be a point where you give a very big increment in voluntary function for each increment of neural preservation. So I think the real relationship is probably exponential. So now many of you have heard about epidural stimulation. And so we know that people who have motor sensory complete injuries and are then exposed to epidural stimulation, they have the ability, sometimes quite quickly, to move their foot, to move their hip or knee. And so what's happened there is it's the same amount of spared tissue, but we've changed the state of the spinal cord, and now we've gone above the threshold to observe voluntary function. So this threshold is very much dependent on the state of the spinal cord. And so even in people with complete injuries, who we normally just write off as not really having rehabilitation potential, that situation can be altered. And just to mention a couple of papers that have looked at this relationship between epidural stimulation and voluntary function over the last decade, and there have been several independent reports that this can occur. Another thing I wanted to talk about is that we have a very brain-centric attitude towards spinal cord function and recovery. We think a lot about the brain stem and the brain in terms of descending systems that are needed to reactivate the spinal cord. But in the last decade, and actually probably the last 20 years, the focus has shifted to the spinal cord that's below the level of injury. And so what we're learning is that there's a lot of network capability in this spinal cord, even though it's separated sometimes from the brain and the brain stem. And so the question is, what can we get out of this residual functional network? The other concept I wanted to go over is the so-called sensory level for paraplegia. So what I've done here is I've drawn, just crudely, this is supposed to be the head, the body, this is the brain and spinal cord. And the sensory level is really determined by residual function of the DRGs and also the ascending sensory systems. And so the definition that we come to in paraplegia is the last normal segments of where sensation can be felt. But I'm going to show you, when you start looking at the motor side, this becomes very limiting. So what is necessary for a movement to occur? Well, we need the motor neurons, we need the muscle, and then we have a lot of integration that occurs. And so what I'm showing here is just some of the inputs to a motor neuron, which are inhibitory or excitatory. So what's happening here is all these inputs influence the postsynaptic potential as to whether this motor neuron will fire or not. So it's a very complex and integrated system. And so what I'm showing here is EMG obtained from a person with spinal cord injury who's having transcutaneous stimulation. This is what the EMG bursting looks like during voluntary activity. And so you can see up here power spectra for different grades of voluntary contractions, 8, 15, and 20. And then this has been decoded into the spike trains that are necessary for that voluntary function to occur. And what this does, it really allows us to see in a kind of binary way the orchestration of successful movements. Now we're going to talk about our clinical trial and the longitudinal neurophysiology that we did. And so the neurophysiological testing sort of fits into this sort of issue of biomarkers that may be useful after spinal cord injury, sort of from a prognostic point of view, and also from a recovery point of view. You know, there are good things and not so good things about doing electrophysiological testing after spinal cord injury. You can detect intact circuits. You can, usually these are quite reproducible if you do them correct technically. You can actually profile an individual as per the residual connectivity that they have in their system, characterize recovery, and then what we hope as the future unfolds is that we'll be able to show the effect of treatment. The cons, neurophysiology tends to oversimplify what's actually happening in the nervous system. There's a lot of technical variability, and the evoked potentials themselves, they're just artificial signals. They're just us putting something into the nervous system and reading it out somewhere and taking advantage of the fact that there's a connection. So it isn't really telling us about normal function. And the other thing is that the evoked potential tells us about a circuit. It really doesn't tell us much about the network of connectivity. So an MEP is induced, in this case, by a coil with the windings that creates a very strong magnetic field for a brief period of time. And this causes current to flow in the brain. And then axons are activated and you descend the spinal cord. And if they make it far enough, they go out to a muscle. And then muscle is an amplifier of signals. So rather small signals can be picked up in muscle, which makes it a very nice way to assess connections. So this is our study. And here we are at pre-transplantation in this particular subject. And this person had no motor evoked potential at all. So here's your stimulus artifact. And then we expect to see something around here, but as you can see, we don't see anything. At 2 months, again, doesn't look very persuasive. At 6 months, we're starting to pick up waveforms. And what you're actually seeing here is the overlay of multiple pulses. And you can see there's a little bit of variability in what these pulses look like. And that's very much to be expected during recovery from spinal cord injury. And then at a year, these are more notable. What's important here, though, is that we have to use an augmentation maneuver, in this case, the Jendresic maneuver, in order to see these potentials. And so had we not used an augmentation maneuver, we really would have been scratching our heads as to whether these small signals were real or not. Another way to look at this, now what I'm showing you are control motor evoked potentials from the tibialis anterior muscle. You can see again the stimulation artifact over here. And these are very reproducible. They look a lot like each other. And that's what we like to see. Now, if we come across to the subject, this is now a person with complete spinal cord injury who was enrolled at baseline with no motor evoked potentials, who now has them. But what you can see is that they are very reproducible. This is one potential after another. But again, they require that reinforcement maneuver to be obvious. For example, without reinforcement, they're quite small. Now, with respect to the content, I want to draw your attention to the fact that the latency of these potentials is almost twice the usual latency of the controls. And the other thing I want to show you is that the amplitude of these signals is extremely small as compared to controls. So it's very interesting that we're able to pick up these small signals at a year. They tell us that there's a connection from the brain and brainstem into the spinal cord and muscles. Now, EMG is able to do more in a way than motor evoked potentials because it's a voluntary EMG that we're studying. And so that integrates additional components such as the will to move and how the motor program is organized. Now, you have to be careful with EMG because it can be very complicated by spasms in people with spinal cord injury and by denervation changes. So you need to make the parameters quite clear. So here, this is how we study EMG. Now, this is the abductor hallucis muscle of the foot, and these green bars represent signals that were given to the subject to say, start your contraction, stop your contraction. So it's a voluntary contraction, and they're supposed to start here. So at 2 months, we have a 20 microvolt signal, and we're not sure whether that's a real voluntary movement or not. But at 6 months, it's quite a bit bigger. It's 120 microvolts, and it starts right away when the signal to initiate movement is given, and it stops pretty much right away when the signal to stop is given. So this is what a voluntary EMG should look like. And indeed, in this particular subject who started the program with a complete injury and no voluntary function, we were able to pick this up. Now, it's even more remarkable because in this clinical trial, there was no evidence whatsoever of motor recovery. So what we're showing here is that sort of beneath the surface, in a person in whom any kind of motor recovery was invisible, we could see an improvement using our neurophysiological tools. So in the trial, the yellow boxes indicate the positives that we found across the 6 subjects. And you see that most of this comes in the abductor hallucis muscle of the foot and in the tibialis muscle. And that's consistent with other reports in the literature that these tend to be the muscles in which one can most readily pick up EMG and motor evoked potentials after spinal cord injury. Another challenge that we wanted to take on is the so-called level. So according to the standard examination shown over here for each of the patients. You know, what's working properly is shown in green. What's questionable is shown in yellow. Questionable means that the score, it can be scored, but it's not normal. And you can see that for all the subjects, we don't get really beyond T6. So now we come over to this person and we want to say, well, what's the motor level? And we figure out the motor level on the chest. And so to approach that problem, we did intercostal recordings, both of EMG and motor evoked potentials, and we did rectus abdominis recordings using needles. It would probably be better to use needles for the intercostals, but some of these subjects were enrolled rather acutely, and there's a little bit of risk when using needles for intercostal recordings, so we didn't do that. This is the paradigm for the intercostals. We're asking the person to initiate a deep breath at 4 seconds, to hold it as long as they can. And so you can see the baseline activity here. Then they take a deep breath and hold it. And so that gives us the EMG activity, which we're able to quantify and determine a value for each intercostal segment. So we studied controls to get at the intercostals because not much is known about this kind of testing. We're sort of in new territory here. And so we worked out what is the expected latency. And so these are 3 different control subjects. And you can see that the latency to the intercostal muscle, T5, T7, and T9, is rather similar across these 3 different individuals. But there's more variability in the size, the amplitude of the signal. So now we're looking at these subjects, 2 examples for EMG. So at baseline, they all had very weak chest movements, and the signals were very small in the intercostals, perhaps because they're recovering from paraplegic injury. There's a lot of change and reorganization that needs to occur for breathing. But at a year, you can see that here we have this start and stop markers. You can see there's a pretty good EMG signal present in the intercostal muscle. And so what do the motor evoked potentials look like? And so the motor evoked potentials are shown here. I know it looks a little busy and complicated, but what we're doing here is we're taking each level for each subject, and we're looking at reproducibility of the latency. And then this is the 2, 6, and 12-month exams. And then we're looking at what's the amplitude of the signal. So here, you can see that across the exams, the latency was pretty reproducible, just around 12 seconds at T5. And the amplitude went up over time, which we would more or less expect in someone who's recovering from injury. There could be other biological things going on here in terms of this improvement. We can talk about that later. But what you can also see is that you have very high amplitudes in the more rostral intercostals, and then it drops significantly in terms of the amplitude. And so we think that there may be an indication of a thoracic level because of changes in the amplitude, let's say from here at T7 to T8. And also when you come up here and look at these latencies, they are quite different. So you can see that there's much more range in the values than there is in the more rostral segments. And so it looks like something's happening by way of a transition across these intercostals. So we did some statistical analysis and we compared the EMG in the intercostals to the motor evoked potentials. And we saw a difference. We saw that over time, the motor evoked potential increased for the upper intercostals, but it decreased for the lower intercostals. And so that again seems to indicate some type of transition in the chest. But when we recorded the EMG output in terms of microvolts per second, we could see that it was going up over the year during the 2, 6, and 12-month examinations. And so the way that we're thinking about this is that their ability to breathe, their ability to use their chest is improving over the course of the year, regardless of whether they have a connection from their brain or brainstem to their intercostal. And that's more or less to be expected because even in a passive way, as the diaphragm moves, there's going to be chest movements. And so we think that this difference, this is really the recovery of the chest, and this is really the innervation of the intercostals. And so the chest doesn't really require that there's a synchronous intercostal in order for breathing to occur. And we did some fairly detailed statistical analysis of these transitions that we see. And so in this example, we found that the transitional delay was 13 milliseconds. And so you can see that the more rostral intercostal muscles have very small standard deviations, and then the more distal have larger standard deviations. And so we argued that this represented a transition from normal innervation of the intercostals to weaker innervation of the intercostals. And then, we tried to tell this story to our reviewers, and they gave us a very hard time. And we spent a lot of time looking at the data and really trying to understand what might have happened. So there's different ways that you could explain this observation. So again, the observation is that below the injury, we're picking up intercostal activity that we would not expect based on the sensor level. So one possibility is that there are branches between intercostals. So here, this intercostal is sending branches to two more distal intercostal nerves. We do know that this happens, but if that happened, the latencies should be very similar across these three. And of course, we were seeing more delayed latencies for more distal intercostal motor neurons. And then another possibility, which we tend to like, is that a residual connection has an interneuron. And we know that breathing is organized through interneuronal systems that terminate on multiple motor neuron pools. So it's not really like, for example, your arm or your leg. These intercostal motor neuron pools, they have to move in synchrony in order for breathing to be effective. And so one of the explanations may be that there's a poly-level or poly motor neuron pool innervation from interneurons, and that's why we're seeing this distal motor evoked potential activity. Another finding that came up with respect to the chest and trying to figure out where's the motor level was the identification of spasms in intercostal muscles. So here you see that T9, and you see 5 to 10 microvolts in this pink bar. At T10, we have a signal that's 1,000 microvolts, and it looks very unusual, artifactual, and we think that this is what a spasm looks like in an intercostal muscle. So just to remind you what's happening here, we're recording everything at the same time. So we're recording 8, 9, 10, and the abdomen at the same time. But we're seeing that there's spasticity in this channel and some spasticity in this channel. So it may turn out that finding intercostal spasticity may tell us where this transitional area for the motor pools in the chest actually is. And so I guess that'll be for another study. But what about the sensory side? We've been talking entirely about the motor side. So you've all heard about somatosensory evoked potentials, and the way they work is you input square waves to a nerve. You have controls. This happens to be at the popliteal fossa, and then this is that around T12. So you put these controls in the system so that you know the signal's getting in. And so those controls are evident in our injured patients. You can see the control from popliteal fossa and then for the T12 area, but we don't see any signal at the brain level, which would be the P37. Now, in the injured people, they do have a normal median nerve SSEP. So how can we see motor evoked potentials and EMG, but nothing on the sensory side? So I think that has to do with the averaging that happens with an SSCP. And so we know that a lot of axons are injured, so they're probably going to vary in their amplitude and at the time at which they arrive after the signal's put into the system. So when you do averaging, they're just going to cancel out. Whereas up here in this cartoon example, they're closer together. And so the averaging algorithm will be able to create a waveform. So that's sort of our working idea about why we didn't see somatosensory evoked potentials. So this is actually the summary slide, and there's a couple more after this. But basically, what we found is it's easier to find a motor signal in the context of complete injury. Neurophysiology can detect connections that are not apparent clinically. So one more time, these individuals really didn't change clinically, but the neurophysiology did change over the course of the year. So it picks up connections that we cannot see with our clinical exam. And neuromodulation is teaching us that even these people with complete injury may be able to do some things when we change the state of the spinal cord using, for example, epidural stimulation. Now, I want to bring up another idea here, which is that repair might occur, but not be clinically detectable. I want to explain that a little bit. So if we go back to where we started, we were talking about paired neural substrate, the use of cells to improve the quality of the spared neural substrate and make it work better, and then the threshold to observe voluntary activity. And we have not crossed that boundary yet. But again, reminding you about neuromodulation, now you have same spared neural substrate, you have brought in the transplant, and now if you layer on top of that a neuro modulation entity like transcutaneous or epidural stimulation, then you do cross that threshold to observe voluntary function. So the idea that this spared neural substrate isn't important is being seriously challenged by new information. I think that's the last slide. So basically what we've talked about is the wiring of the spinal cord by way of evoked potentials and EMG, a little bit about the state of the spinal cord in terms of whether it's being exposed to neuromodulation. Finally, I want to end on just this topic here, because the spinal cord below the injury is not working right. And so one of the emerging stories has to do with chloride in these neurons. And so one of the important transporters, which is known as the KCC2, potassium chloride cotransporter, we know it's downregulated in spinal cord injury tissue. And so right now we're looking carefully at this as a possibility for chemical neuromodulation. So that's it for me. I want to thank you very much for your attention, and I'd be happy to take any questions.
Thank you, Jim. Very nice presentation. Any questions from the audience?
Hey, Jim, great work. Alan here. I just wondered if you could maybe some people in the audience don't even know what a Gendrasic maneuver is. And if you could comment on that and what you think physiologically or electrophysiologically that does to the signal.
Right. So there's a lot of theories about, so a Gendrasic maneuver is something that you do to cause muscles to tighten in the area of normal innervation, and in order to increase the output of a signal below the area of the injury. And so the classic one was what I showed the person was doing, which is taking their fingers, interlocking them and pulling apart. But you can get the same effect with neck flexion, or you could get it even with a biceps contraction. So you're using a sort of a trick in the nervous system to use the innervated muscle to increase the output in the, let's say, weakly innervated muscle below. And so the classical idea of the Gendrasic maneuver was that it reduces presynaptic inhibition. And so there's a lot of presynaptic inhibition is going to affect how much neurotransmitter is released, for example, onto the motor neuron. So if we reduce presynaptic inhibition, we tend to get larger signals. And so there are other theories of how it works, but let's just stick with that one for the moment. Any other questions?
I was going to ask, so it appears that, the way this field is going is maybe cell therapies plus some type of neuromodulation. And you talked a lot about epidural stimulation, and obviously you're involved in a deep brain stimulation project as well. I'm just wondering, the early data on plasticity had to do with pharmacological agents in terms of, as you said, inhibiting, some parts of the synapse and things of this nature. Is there a strategy by which we could integrate some of the pharmacological strategies to try to enhance circuit plasticity and reorganization and recovery of function?
Yeah, I mean, I think that sort of when I entered the field, there was a drug called 4-aminopyridine that was topical in the sense that it was claimed that it could increase the transmission across demyelinated segments. So I think that the word neuromodulation is a little artificial, because there are a lot of drugs that we can use that are also neuromodulators, and a lot of our pain medications themselves are also neuromodulators. So we've talked in our meetings before about ways that we might be able to predict that a person would be a responder in a biologics clinical trial. And so to do that, we might want to do some of these augmentations of the nervous system, for example, transcutaneous stimulation, to determine whether we can see clinically that the person has preserved connectivity. Just going back to the KCC2 for a minute. So what happens there is that after TBI, after spinal cord injury, after stroke, people with Rett syndrome and so on, they have very abnormal management of intracellular chloride. And so the result is that they accumulate intracellular chloride. So now when GABA binds to its receptor, the current goes outwards. Instead of having a depolarizing current, they actually have it. Instead of having a hyperpolarizing current, they have a depolarizing current. So I think when we talk about neuromodulation, we also have to include drugs that influence the membrane potential. Did I answer your question?
That's good. That's good. I mean, I'm just looking for other alternatives that have maybe could build some synergy to some of the things we're doing. So, there's a big area now in intermittent hypoxia, for example, in terms of improving respiratory function. These are the types of things maybe one day we'd like to put on top of cell therapies or, neuromodulation, those types of things. So that's where I'm going with this. There's a lot of things out there that people are working on independently. And if we could put some of these things together that made sense, it might actually enhance circuit recovery. And that's where I'm getting at.
Yeah, and I think it has to eventually be durable. It has to be durable. Like we can get transient effects that last for a few hours, but I think we really want to get things that last for months or years.
Very good. Okay, thank you. I think any other questions from the audience? Thank you, Jim. Thanks, everybody. Have a great afternoon.
Nice day.
Great day.
Bye.
Take care. Bye-bye.